Great. Good morning, good afternoon. Welcome to SCRC's Public Talks. I'm Joanne Darnell. I am the co-director for our Team Science Core, which leads our pilot grants program and collaborating scholars program. And I am so excited, pleased to introduce you to Taylor Ryan. Taylor Ryan is a research program manager at the Johns Hopkins School of Medicine and a doctoral student at the University of Washington School of Public Health, with a concentration in implementation science. Her work focuses on suicide prevention, particularly youth suicide prevention, mental health stigma, and access to upstream suicide prevention strategies such as mental health programming in schools. We'll have Taylor talk to us for a bit, and then we'll save a little time for Q&A at the end. So if you would like to put something in the chat, I will be monitoring that to address those questions at the end. All right. Thank you. Taylor.
Great. Yeah, thank you so much. And thanks so much for having me. Let me pull up my slides. All right. 1 second. Um, okay, perfect. Can you all see the slides okay? Great.
Looks great.
Yeah, awesome. Yeah, so today I'll be talking mostly about my dissertation work, but also a few other youth suicide prevention projects that I'm involved in. But the title of my presentation today is Evaluating the Implementation and Effectiveness of Clinical Care Pathways for Youth Suicide Prevention. And yeah, just a quick agenda. So I'll give a quick overview. I know most people on the call are probably pretty familiar with kind of the background just surrounding rates of youth suicide in the United States. So I'll give a brief overview. Next, I'll talk a little bit more about some quantitative evaluation, both that I guess has already been done within the Zero Suicide Framework on adults, but then also my planned research around this in adolescents. I'll then talk about some qualitative work I'm planning to do related to adolescent risk identification and screening. And then finally, at the end, I'll give kind of just a quick overview of some of the work we have going on here at Hopkins. And then, yeah, as mentioned, hopefully we'll save some time for some good discussion at the end. Yeah, and so real quick before we jump in, and I'll give more detail about this at the end, but I really just wanted to acknowledge these three specific institutions. So Kaiser Permanentes and the Mental Health Research Network there, they've been really generous in providing me access to their data and giving time and mentorship. And then, of course, the Department of Health Systems and Population Health at UW, which is where I am doing my PhD. And then finally, the Johns Hopkins Center for Suicide Prevention. So yeah, a lot of my dissertation work has been supported by these groups and folks within these groups. I just want to give them a quick shout out. And then before I get into my talk, I just like to give kind of a quick positionality statement because I feel like it's really important for people to kind of understand where how I approach my work and some of the things that really influence how I look at the work I'm doing. So I use she, her pronouns. I am a white cisgender female. I grew up in the suburbs of Philadelphia. And yeah, as mentioned, I'm a fourth year PhD student in health services. And then I also recently moved back from Seattle to the East Coast to take a role as the research program manager at the inaugural Johns Hopkins Center for Suicide Prevention. In this space, I also identify as someone with lived experience, which I think is important to, again, how I approach this work. And then just want to note that I don't have any disclosures or conflicts of interest to mention. Okay, so why focus on the health system specifically? So I want to take a minute, just this is a little bit more of like on a personal note. So obviously there's a lot of like reasons related to research, which I'll get into in a minute, that why it makes sense to really focus suicide prevention efforts on health systems. But for me, when I finished my So I did a combined 4+1 bachelor's, master's degree. I was fortunate to get hired by Dr. Holly Wilcox at Johns Hopkins as a research coordinator. And I think it was here that I had known that I really wanted to pursue a career in policy and research for suicide prevention. But in this role, I spent a lot of time working with youth and their families in the pediatric emergency department. And I think here, specifically, it really kind of hit me why there's such a big need to focus on health systems. Um, so, while a lot of the patients that I worked with as a research coordinator really stuck out to me, there's two that, I really comes to mind when I think about this work. One was a young patient who, when I was talking with them and doing kind of our clinical interview, I asked them to describe how they were feeling, what their depression felt like. And, he kind of looked at me and he said, my depression in my head is what it feels like sitting in this psych pod here in the ED. And I think he was kind of referring to, when psych patients come into the emergency department, they are oftentimes put into a room with nothing but a bed for safety reasons. And of course, give a lot of credit to all the clinicians, and there's so many of them doing such amazing work. But I think from like a system perspective, there's a lot of places where we're failing our patients. Um, and similarly, the other patient that really came to mind, and I think I wrote about actually in my application to the health services program, there was a young person that came into the ED, and they had some pretty severe intellectual disabilities. So because of that, they couldn't just go to a normal inpatient unit. They had to go to a neurobehavioral unit, which, wait lists for beds are already super long just in the general psych units. But for this patient in particular, waiting for what they called an MBU bed took much longer. And so I think this patient ended up being in the PZD, just kind of being held there for over like 25 days. It was almost a month. But one thing that really stuck out to me is the patient kept experiencing a lot of like outbursts, and they kept, for safety reasons, removing everything from her room. So essentially just a mattress. And the one day I went into the ED, I was talking to one of the nurses, and they said that her outburst, like that day, was due to the fact that there had been a fly in her room that she made friends with, and it had left the room, and she was like completely distraught. And I give a lot of credit to the clinicians and the nurses, as they kind of are trying to troubleshoot on the, in real time, like ways they could kind of engage with this patient, such as like going for a walk with them. But I think to me that really spoke to this whole like trickle down issue, right? Like we don't have enough providers, and then we don't have enough beds. And so what are ways that we can enhance our existing structures, and then even just get more innovative and come up with other ways to basically support our patients, and ideally not have them even end up in the ED. But anyway, that might feel like a bit of a tangent, but I think it's just important to know, and especially as a researcher, I sometimes get a little bit lost in the data. So it's always helpful for me to think back to these people and just, remember these are real patients and stories that our work is helping on a daily basis. So with that, like I mentioned, I'll give a really quick background. And again, I know most folks on here are probably familiar with a lot of these stats, but yeah, so youth suicide is in the top 3 leading causes of death for youth and young adults ages 10 to 24, and this is in the United States. And in 2023, on a national survey, the Youth Risk Behavior Survey, about 20% of high schoolers reported experiencing suicidal ideation, and almost 10% reported actually having a suicide attempt. The other thing I want to mention, because this will be a little bit important later as I'm going through some of my planned dissertation work, we're seeing a huge disparities arising in youth suicide. In particular, one statistic that really struck me. So in 2021, which was actually, I guess, right kind of during the height of COVID, suicide rates in the US actually slightly decreased for the first time in a couple of years. But after doing further stratification, researchers actually found that there was a 30% increase among Black individuals and a 16% increase among individuals who identified as Asian or Pacific Islander. So I think it's just important to note that we're seeing these emerging disparities. And I know too, a study out of Maryland similarly found an increase in suicides around the same time in Black youth. So I think really centering around this equity issue as we're talking through zero suicide and doing this work is really important. And then I know I mentioned that I would kind of talk a little bit more about the research related reasons for why focusing on health systems. I know I gave some of my own anecdotal reasons, but a big thing is that we know from the research that a majority of people who die by suicide see a healthcare provider prior to their death. And some work by Brian Amadami and colleagues, they actually found that almost 90% of patients see a healthcare provider within a year of their death. And when this was, this healthcare context before death was looked at in young people, about 40% saw a healthcare provider within a month of their death. So this really just speaks to this, like, we have like a really unique opportunity to intervene at the health system with people at risk of suicide. Great. Okay. So as mentioned, my dissertation work will focus specifically on a zero suicide model or data set. So for those of you who aren't familiar, although it sounds like there may have been a prior talk related to this, which is great. So hopefully this will build off of the prior talk you heard on zero suicide. But this program or model, it really emerged from the Perfect Depression program at the Henry Ford Health Systems. And from this model, basically it was, a systematic implementation of a clinical care pathway for youth at risk, or sorry, for patients at risk of suicide. This was all patients. And they found like significant reductions in suicide attempts and deaths in those health systems that had implemented it. So due to this, in 2012, the US Surgeon General in their national strategy for suicide prevention decided to develop and kind of coin this framework as the zero suicide model. And really what it is, it's a bunch, like when you go on zero suicide and look at these models, they offer kind of a package of various like tools or strategies, really from screening, so like risk identification, to brief intervention, to follow-up care. And I'll get more into the specifics of that. But it's the goal of it is really to allow health systems to develop these really robust, care pathways for patients. One thing I will mention, I know that there's a critique among some people in the field that zero suicide, because it's so aspirational, this like connotation of no suicide deaths. And I know sometimes clinicians might feel like it can contribute a bit to like a blame culture around patient safety within health systems. And I just want to say, like, I personally fully acknowledge that. And I want to mention that, in the context of my work, I'm using it more as just the framing of the clinical care pathway. And I think it's just useful for me to kind of conceptualize that. So I just want to recognize again, that I think this framework can be extremely valuable and important, but obviously, like any framework, doesn't come without limitations. And with that being said, in mentioning, the utility I see in zero suicide for kind of framing up my study, I really like this specific framework wheel that the suicide prevention or zero suicide folks have put out. So the 7 kind of pieces that they talk about in terms of implementing zero suicide is lead, train, identify, engage, treat, transition, and improve. And one thing I really like about this model is they actually break it into 2 sectors. So essentially they break it into like clinical functions, which is the identify, engage, treat, and transition portion. And then they break it also into like an implementation function, which is train, lead, and improve. And as a hopeful implementation scientist, I kind of really like how they um, have included both the implementation and clinical side in this model. So real quick before I jump into my specific project, I want to talk about a big zero suicide evaluation that was conducted in adults and has inspired a big portion of my first two aims of my dissertation. Um, and I want to give special thanks to Dr. Brian Amadami and his team over at Kaiser Permanente. So Brian, Dr. Amadami led this study, and he was generous enough to let me share a bit about it. I will note the publication is in press and will be forthcoming. So yeah, definitely we'll look out for that. But yeah, very grateful that he's letting me share some of this work. So basically, in his study, he looked at what kind of, just to make things a bit simpler, we're calling the National Zero Suicide Model. So this was a group of um, different health systems across the US, all kind of associated with the Kaiser Permanente Healthcare Institute. So this was the Henry Ford Health System in Michigan, and then Kaiser Permanente groups in Washington, California, Colorado, and Oregon. So essentially what this study did across these six health systems, there were various time points in which the zero suicide model was implemented. So they were basically able to do an interrupted time series with segmented regression with two control sites to basically see if implementing the zero suicide model had an impact on patient suicide attempts. So four sites served as the intervention sites, if you will, and they all had kind of staggered implementations from 2012 to 2019. And I'll show a graph in a minute, kind of just depicting the implementation. And then there was two sites which they referred to as like post-implementation. And these two sites had already implemented the zero suicide model previous to 2012 and kind of served as control sites for these studies. And so basically the research team was able to gather EHR data and insurance claims, and they were able to calculate crude standardized rates of suicide attempts per month per health system. And that's kind of what they use to look at if these rates increase or decrease post implementation. And so here real quick, this graph, and apologies, it's a little hard to see on here, but this just shows the implementation across the four intervention sites. And yeah, as I mentioned, they all implemented at slightly different times. So site A was in December of 2017, site B was in April of 2019, site C was in April 2017, and D was in October 2016. And then this slide is kind of the really important one because this shows the results of the ITS analysis. And as you can see across the top are the four intervention sites. And so all of the sites except for site D had statistically significant declines in suicide attempts, in monthly rates of suicide attempts. And while the site D didn't have a significant decline, it did have a like sustained lower rate of suicide attempts in the follow-up period. And then as you can see on the bottom were the two control sites, and they all demonstrated a sustained decrease. And site Y in particular had a really substantial, significant decrease. And the researchers, in addition, did a brief secondary analysis where they looked at quarterly rates of suicide deaths, and they did find significant decreases in sites B and C. So as I mentioned, this will be forthcoming, so hopefully it'll come out soon for you to all look at, but I appreciate Dr. Amadami letting me show these slides to you all today. And what I really want to take away from this is that obviously the zero suicide model, I think, shows a lot of promise and utility. These clinical care pathways do seem to work in reducing suicide attempts and deaths. Um, but I also want to note, and the authors in the paper note this, so these were all done. Dr. Amadami's paper was looking at mental health outpatient clinics specifically. So it'd be great to view this work in primary care and other health settings, and also specifically with youth, which kind of leads me to my dissertation work. But before I jump into the specifics of my planned dissertation project, one kind of other little side project I thought would be useful to mention because it relates to some of the work I'll be doing was the ICD-10 transition and its impact on rates of suicide attempts and deaths. Um, so those most of you are probably familiar, but ICD-10 codes are essentially used to code clinical diagnoses when patients are seen within our health system, and a lot of these are used for billing. So in 2015, the United States actually transitioned from ICD-9 to ICD-10. And this is really important for a lot of like large scale suicide prevention evaluations that kind of cross over during that transition time period. Because under ICD-9, there were these external codes or E codes, which were applied to a primary diagnosis code. For example, a self-harm code would be added to a primary injury code, and these E codes weren't billable. And so when the shift to ICD-10 occurred, they essentially eliminated the E codes and just made them part of the primary code, and thus they were now billable. So things like self-harm now became a billable part of the code and thus started being used more widely. And so Chris Stewart and colleagues at Kaiser did some work on this in adult populations and did find that, it seemed that the rates of suicide attempts and self-harm increased during that transition period. But of course, it was due to this like artifact of coding. So I was fortunate enough to work with two of my mentors, Rob Penfold and Julie Richards, in replicating that study in youth. So real quick, this is work we have in process, but I just wanted to show two of our graphs of our interrupted time series. So yeah, we basically did an interrupted time series analysis of code ICD-9, ICD-10 codes associated with self-harm and suicide attempt across various health systems. And as you can see, so October 2015 is was when the transition went live. And so this graph right here shows this transition in youth ages 6 to 11. So we split our analyses into youth 6 to 11 and then youth 12 to 17. So in the 6 to 11-year-olds, there was an immediate 0.19 increase in the rate of monthly suicide attempts. And while this wasn't significant, it was still an increase. And I will say in this post period, there was a 0.18 increase in monthly rates of suicide attempts. And this was significant. But then kind of really, I don't know if I'd say shocking because it makes sense given the transition, but this ITS analysis among the 12 to 17-year-olds showed a major difference in the pre to post transition of ICD-10. So as you can see, the dotted line in the middle, right when the transition went live in October 2015, there was almost an immediate 38.54 increase in the rates of suicide attempt. And then that sustained at about 6.47% across the follow-up transition. And so this might seem a little bit unrelated specifically to my work, but I thought it was really important to talk about here because I think it has a ton of implications for my study in particular because our zero suicide model was implemented during this transition. And so I do think our results will be heavily biased towards the null. So I think just we need to use caution when interpreting this, just because there's likely bias due to like the coding artifacts. So with that being said, I'll jump into my specific dissertation work. And I'm going to focus on my first two aims first, and then I'll jump into my third aim. But as you can see, here's my three aims. So aim one is to identify gaps and barriers in the implementation of the zero suicide care pathway for suicide prevention and care among adolescent patients at 6 large healthcare systems with diverse patient populations. Aim two is to evaluate the effectiveness of the implementation of the zero suicide care pathway for preventing suicide attempts among adolescent patients via interrupted time series analysis. And then my third aim is to conduct a qualitative evaluation of opportunities to improve the suicide care continuum from the perspective of youth who reported having no thoughts of suicide in close proximity to a suicide attempt. So I just really quickly wanted to share here, and I apologize, this is a bit busy of a slide, but here is a conceptual model that I pulled together to highlight all of my dissertation work. And I really wanted to combine a few different frameworks and strategies. And so I tried to kind of overlay that onto the aims of my study. The key things I just want to point out, which I won't go in depth just for the purposes of this talk, but I kind of wanted to pull in a suicide prevention framework as well as a health equity framework, and then an implementation and dissemination framework. So again, won't go into detail, but the frameworks I chose were the suicide care cascade, which I'll talk about in a minute. And then for my health equity framework, I am looking at the health equity implementation framework. And then for my implementation and dissemination, which will mostly be used in my third aim, I'll be looking at REAIM and then the consolidated framework for implementation research, or CFIR, which a lot of you might know about here. So as I mentioned, the one framework that I'll talk about here a little bit more in depth is this cascade of care model for suicide. And this one I think has really informed a bulk of my specific study, which is why I wanted to give a little more time and detail to this one. So this was a model developed by Emily Harris and colleagues, and I'm fortunate enough to get to work with Emily over at Hopkins, so that's kind of exciting. But her and her team did a really good job of, in my opinion, of building out this framework. Basically, they took cascade of care, which is COC for short. This was a model that was previously used in things like HIV, public health care for HIV prevention. So I think historically has been well applied in other areas. I've also seen it used in like cancer prevention models. So just, this is pretty recent in 2023. Dr. Harrows, she developed what she kind of coined the COC model for suicide. And it really takes a public health approach to looking at preventing suicide. And so as you can see, kind of the green, these green hexagons throughout are her model. And then I tried to kind of overlay that with what I was looking at with the zero suicide care pathway. But in the COC model, they conceptualize the suicide clinical care pathway as identifying characterized level of risk, intermediate intervention, link to care, outpatient or community care, and then recovery and resilience. So here kind of gives, or sorry, I'll go back for 1 second. So for my specific study, I'm mostly going to be focusing on the first 4 pieces of this, and recovery and resilience will hopefully be an ongoing step, but I've mapped on the identify, engage, treat, and transition pieces of the zero suicide care pathway to this model. And then real quick, I wanted to show how I'm conceptualizing specifically the zero suicide care pathway that I will be looking at. So yeah, basically I'll be categorizing the pathway into 4 categories. So screening and risk identification, assessment, brief intervention, and follow-up. And just in terms of how I'll be like the variables that I'm associating with each of these 4 categories. So for screening and risk identification, we'll be using the PHQ-9, which most of you are probably familiar with here, but it's a popular depression screener, and the ninth question asks about suicide risk, and that's what they use in the Kaiser health systems that I'll be looking at. For assessment, I'll be using the Columbia Suicide Risk Screener, which again, a lot of you I'm sure are familiar with, but gives screens for variation in suicide risk. For brief intervention, I'll be looking at rates of safety planning and lethal means counseling. And then for follow-up, this will obviously be referrals and then also additional appointments for care. Okay, so my planned analysis for AIM-1, I'll basically be looking at patients ages 13 to 17, and this will be in that national zero suicide from the zero suicide data set, which includes the 6 health systems that I mentioned previously. And one thing that I'm kind of adding to this analysis is we're going to include the primary care data as well as the mental health specialty visits. And I think this is especially important because I know the work I talked about earlier, where I discussed how most patients who die by suicide are seen by a healthcare provider. Interestingly enough, that data shows that a majority of those visits are to primary care or medical specialty appointments. So not necessarily the mental health piece. So I think it's really important that we're including primary care in this work because this is a place that we might be able to catch more patients who are at risk of suicide. And so this first theme is going to be more descriptive in nature. And my main outcomes will be the proportion of you screened for depression with the PHQ-9, those assessed for symptom severity, again, with the CSSRS, those engaged in safety planning, and then finally, those engaged in follow-up care. And as I mentioned in the beginning, I think one thing that I'm really interested in this aim is to basically see what youth are being screened and connected, but also what youth might not be. So I have some planned analyses and stratifications by race and ethnicity, as well as age and gender. And I think this will be really important because given the rising disparities, I think we'll hopefully be able to get a sense of if there are emergent disparities just in who is even being screened in the first place. And similarly, once someone's screened, who's actually being kind of, pushed along this clinical care pathway. And then my next analyses will be really similar to Dr. Bayan Ahmadami's paper that I shared earlier. So again, this will be an interrupted time series analysis with segmented regression. And I'll be looking specifically at youth, so patients 13 to 17. And again, here I'm including the primary care, which will be like kind of a unique new addition, I guess, to this analyses. And so similar to his study, we'll have 4 intervention sites and 2 comparison sites. Our primary outcome will be suicide attempts or deaths in the 90 days following a visit to either the mental health specialty visit or the primary care outpatient visit. And so again, I'm hoping to basically see if the implementation of the zero suicide model had an impact in youth ages 13 to 17. And then also, again, I think the primary care piece will be really interesting to see how that compares to the mental health specialty. And then for my third aim, which while all the aims are important, I will say I'm probably most excited about this aim. I'm specifically going to be focused on improving risk identification for youth. And I think this is really important because as we know in the data, a lot of youth who are actually screened for suicide risk, so for instance, who are asked the PHQ-9, not all, there's a large subset of kids who won't endorse their risk, even when asked. And building off of some work from one of my mentors, Julie Richards, her and her colleague Ursula Whiteside did a study, and they found that about 24% of adult patients did not report basically did not endorse that question 9, which assesses for suicide risk in the week before their suicide attempt. And then similar work by Dr. Jean Flores and colleagues also found that almost a third of youth who attempted or died by suicide did not report risk in the 30 to 90 days prior in the PHQ-9. And I think this is really important, especially in the context of this clinical care pathway. As you can see, I've kind of put this star right on step one. To me, making sure that we're identifying people is especially important because in order for you to get into this pathway, they essentially need to screen into it. So I think we could potentially be missing a whole subset of kids because they're not endorsing risk. And, in the adult populations, Julie Richards and colleagues found that a lot of them said it was either due to stigma, like not wanting to answer truly how they felt, or they indicated that at the time of the screening, they didn't actually feel suicidal, so they didn't report it. But, anecdotally from my work in the emergency department, I'm also thinking that, there's a lot of kids that I would have tell me, like, I know how to answer these questions if I don't want to stay here. And I do think that's, a common thing for kids. And so I'm really hoping that this aim will give us a little more insight into what might be effective to capturing all kids at risk of suicide. So with that, my planned analysis for my third aim will be recruiting patients with a documented suicide attempt who basically screen negative on a suicide risk screener within 90 days of their attempt. And I will likely be recruiting this sample from Hopkins, which I'm excited about because Hopkins serves a pretty diverse, since we're in Baltimore City, a lot of the patients do identify as Black or Hispanic or Latinx. And so I definitely want to make sure I'm including just with the equity and the emerging disparities. I think they'll be really interesting. I'll likely be looking at the PHQ-9, although there might also be opportunity within the Hopkins system. A lot of places also use the ISQ risk screener. And so that could be a potential opportunity. And I will acknowledge, of course, there's always limitations with the screener itself. I know a caveat to the PHQ-9 is that it's more of a depression screener than a suicide risk screener. But I'm hoping this project will at least be kind of a first step in the direction of figuring out ways that we can better identify risk in youth. And my plan for analyses is kind of a combination of inductive and deductive coding. And again, I won't go into detail here, but for my interview questions, at least for the inductive ones, I'm planning on building them kind of around the consolidated framework for implementation, which is a pretty popular, implementation related framework. So there's various domains. So I'm hoping to map my questions onto these domains. And then also the health equity implementation framework. They also have some key domains that I'm hoping to kind of map my questions onto, just so I can make sure that my interview questions are informed by these validated frameworks. So before I kind of finish up and talk about some other work that we're working on over at Hopkins, just for my dissertation work, this is a table I made just to kind of show, again, so mapping my aims onto the suicide COC model that I mentioned, as well as the zero suicide care pathway. So as you can see all the way on the right-hand side, my aims so far identifying and characterizing, I think we'll see in aim 1 and 3, a lot of the potential disparities and also potential barriers that we might be seeing with identifying kids at risk of use. So that first part of the pathway. For engage, aim 1, obviously, we'll be able to tell kind of the rates of those engaged in safety planning and lethal means counseling. And similarly for treat, again, aim 1. I also think a little bit of aim 3, while that won't be the primary focus, hopefully from these qualitative interviews, we might be able to get a better sense of some of the treatment these youth might be seeing. And then finally, so reduction in suicide attempts and deaths will definitely come from aim 2, which is my interrupted time series analysis. But I've left the outpatient and community care and the recovery and resilience piece, which I've mapped onto the zero suicide care pathway as transition. I highlighted these in gray because I think a majority of my dissertation work will cover these first three elements of the pathway, and then this transition piece will probably, be a next iteration of future work. So before I wrap up, I guess we have a few more minutes here. I wanted to quickly highlight just some other youth suicide work we're doing at Hopkins. And yeah, especially I think it would be great for future collaborations with this group. And yeah, I just want to highlight some of that going on. So as I mentioned, I moved back to the East Coast recently to help support the inaugural Johns Hopkins Center for Suicide Prevention. So we actually just launched our center basically right in the new year. So it's kind of still in process, but I wanted to highlight there are three kind of main directors of the center. So first is Dr. Holly Wilcox, who's the director and founder, and she's been a really it's been a long time mentor of mine. So I'm really fortunate to have been able to work with her for all these years. And then there's Dr. Paul Nestat, who's our medical director, and he's a psychiatrist by training. And then Dr. Emily Haraz, who's the deputy director. And as I mentioned, she is the one who actually developed the COC model that is informing a lot of my dissertation. And so while the aims of or I guess our main goal for this new center is really to inform research and policy, and I think Holly or maybe Paul will be on, so they might be able to talk more about this if people have questions. I've also included the website, and I'll have my email at the end. But while we have a kind of a lot of projects going on, I really wanted to highlight two related to some of the youth work. So first, and I've been pretty heavily involved in this study, is Dr. Wilcox's study, which is a PCORI-funded study titled Preventing Suicidal Behavior with Diverse High-Risk Youth in Acute Care Settings, or as we've named it, the HOPE study. And this is a multi-site study. So we have 6 different academic medical centers. So it's Johns Hopkins All Children, Columbia, Cornell, UNC, and Children's Hospital of Philadelphia. And we're recruiting youth at risk of suicide from the ED. And they're going to get randomized to safety planning, intervention, plus follow-up context, or IPTA, which is a brief, it's basically a brief set of 5 therapy sessions. And we'll follow them for a year, for 3, 6, 9, and 12 months. We'll also have parent caregiver interviews. So again, I know we're short on time, but just wanted to highlight this as some of the youth work we have going on. And then one other study, which I'm involved in, and this is a little bit different, I would say, than the healthcare work, but we have been working on a youth-aware mental health, which is a validated youth suicide prevention program, also known as YAM. And so Dr. Wilcox has been working on this for a few years now, but they worked to adapt this program. It was originally developed in Europe, and some of you might know of the big Sealy study, which was a big randomized control trial in which they found that YAM over in Europe led to a decrease in suicide attempts among schools that had been exposed to the YAM program. So we brought it to Baltimore and are adapting it, and we're currently implementing it in middle school and high schools in the city. And I actually just recently got trained in YAM. I was fortunate enough to attend the YAM training and they brought over, some of the developers from Europe. So I'll be helping to implement that in schools. And I know I mentioned a lot about healthcare today, but I do have a specific passion for the school-based work and upstream. So I'm excited about that. And in particular, there is one charter school in Baltimore known as KIPP, and they have what's called the Rails Health Center. And as part of this project, we'll actually be screening kids for suicide. And the kids who screen positive will get connected to a community health navigator. So we're really excited about this. And I do think it ties back to my work in that I think implementing programs like this in the community can really help support, keeping youth potentially out of EDs and can just kind of help, like I said, with this upstream prevention processes. And then finally, I won't go into detail, but just highlighting a few other studies at our Suicide Prevention Center here at Hopkins. So there's a large trial right now going on called Collaborative to Understand Impacts of Early Preventative Interventions on Suicide and Overdose Mortality. using data harmonization methodology. So this again is a multi-site study, and the researchers are looking at various basically suicide-related programming, and it's longitudinal, which is really cool. So looking to see if it led to reductions in suicide attempts to death and also substance use. The other study, which is really spearheaded by Dr. Podnestat, is psychological autopsy to better understand proximal dynamic risk for suicide. So for those of you who aren't familiar with the psychological autopsy work, it basically involves interviewing next of kin of people who've died by suicide to really do in-depth qualitative work to try to figure out potential, where there could have been potential interventions to prevent the suicide death. And so he's doing one of those among youth. So we're really excited about that. And then finally, third project I wanted to highlight is a state suicide prevention policy review. And that's really being led by Dr. Emily Hero. So looking at different states to see where there's like effective and different innovative suicide programming going on. So again, apologies, that was a quick overview, but definitely will feel free to ask questions at the end, and I'll leave my email as well. And then before I open it up to questions, I just wanted to give a few quick acknowledgements. So first to Dr. Julie Richards and Rob Penfold from Kaiser. They've been instrumental in kind of getting me access to this data and helping me develop this project. So I'm really grateful to them. And then Dr. Holly Wilcox, as I mentioned, I've been working with her. She started working with her like fresh out of my undergrad, and she's just been really instrumental in my career path. And I feel really fortunate to be back working with her again. And then, of course, my entire dissertation committee. Definitely want to acknowledge Dr. Jenna Van Dranen. She's been such a great support and really instrumental in my doctoral work. And she's the chair of my committee. So want to give her thanks, as well as Dr. Brad Wagner, who's my GSR. And then again, the rest of my committee is made up by Drs. Richards, Penfold, and Wilcox. And then, of course, the Mental Health Research Network at Kaiser, all the patients and researchers involved in the National Zero Suicide Model, the UW School of Public Health, specifically the Department of Health Systems and Population Health. And I think some of my cohort mates are on this call today, and I'm always so thankful for them and all their support. And then, of course, the center here at Hopkins. So Drs. Wilcox, Nestat, and Haraz. And then finally, thank you to the Suicide Care Research Center for having me today. I really, really appreciate it. So with that, I'll open up for questions or comments, feedback. And I can stop sharing my slides in a minute just so we can actually all see each other, but I'll leave with, here's my email address. So please feel free to reach out with any questions, comments, or suggestions.
Wonderful. Thank you, Taylor. So great to hear about the exciting work you're doing. We don't have any questions in the chat, but you can chat comments, questions, or just go ahead and unmute yourself.
I'm really trying to put my hands on, sit on my hands. Taylor, this group knows that I'm a big blabber, so I
No
if
worries.
there's anyone else who has a question, I can wait.
No worries at all. I appreciate it.
Okay, let me go ahead and get the group started then. Taylor, this is just super awesome and important work. So thank you for doing all of this. My name's Ian. I'm a family physician and, work in family medicine, psychiatry, and global health on depression, risk of suicide in non-specialty settings. And, I've been super interested in the zero suicide model as it relates specifically to, non-mental health settings. And I was curious about, well, I guess I would just say that I think that you'll find that there are going to be holes, in
Yeah.
what's happening in primary care. And so I'd really encourage you to, as you're moving forward with your skill development, to really think about the qualitative mixed methods, kinds of things that you can do on the ground to explore these things. And, we've been working on stuff like that for a while. And of course, all of it should be like engineered around, okay, how do we move forward with patching those holes in a way that makes sense to the sites themselves? So I was kind of curious what you've been thinking about that sort of thing, and how to work with primary care sites where the incidence is going to be super low, right? And there's
Right.
so many things that are distracting everybody, but this is such a critical area.
Yeah, definitely. And I appreciate you bringing that up. One thing I didn't mention, I've tried to frame my whole dissertation into a mixed method study, specifically like an explanatory sequential, where I'm going to use the first two quant aims to inform the fourth qual aim. But yeah, I think, yeah, your point is super well taken. And I agree. I think we're going to find some holes and areas that we'll need to focus in on more. I'm hoping really with aim three in particular, with the qualitative interviews, that we might be able to capture some kids that we're seeing in primary care specifically. But I do think additional work will need to be done. I realize obviously there's some limitations with the first two aims just being quantitative. And I do think down the road, it would be great to do qualitative interviews with maybe primary care providers. And actually, I was going to mention that Dr. Julie Richards, I don't think she could make it today, but she was doing some of that work in primary care. So actually like interviewing providers. Um, so yeah, I think that's definitely for some future work. I don't know if that helps answer your question though.
Yeah, I mean, I just think that it's, the actual delivery sites, the patients, of course, their perspective are critical, right?
Yeah,
But the folks who can actually make some kind of change, those would be not just the providers, though, be careful about that. Like, it's really
yeah,
the whole system, the medical assistants, the people at the front desk, whoever's doing the screening. You'll see some places that have huge screening rates, but very little detection. And that's
yeah,
just as bad as not doing screening, right? Like they're not
yeah,
effectively screening. So many different things. And then the
absolutely.
follow-up, like how do they, just be detecting it, they might not realize they've detected it, right? Then it's not really detection. It goes into the EHR, but no one noticed that that ninth question on the PHQ-9 was positive, or nothing, no actions were taken, and there's no infrastructure to follow them, all of those kinds of things.
Yeah, absolutely. Yeah, no, and I totally agree. I think there'll be a lot more work to be done from a systems level perspective to make sure that we're really fully supporting kids along the whole pathway.
Thanks for your comment, Robert Penfold. I'm reading yours in the chat, and thank you, Ian, for kicking us off. I do appreciate that. Good to keep in mind that all the positive results from the zero suicide work so far apply to people seen in specialty mental health settings. So, do you or does anyone else want to comment on that comment?
Taylor, you want to take that?
Oh, sure. Yeah, I can, and I'll pass it to you, Rob. But
Yeah,
yeah, that's
sure.
a really good point. Yeah, as Rob mentioned, and I think Dr. Amadami's paper that I highlighted was all mental health specialty. So that's kind of I guess, maybe more unique element of my planned dissertation work is that we're planning to include the primary care sites. And so I think it will be really interesting to see because yeah, as you brought up, Ian, like I think there'll be a bit less of that going on because they're not, in mental health, we're more keyed in specifically to the screening and follow-up and safety planning. But I think it'll be interesting to see. The other thing I was going to mention too is I know Dr. Julie Richards has a paper more so related to the implementation of zero suicide. And I do think that's been a big part of this work with this national zero suicide model is being able to work directly with people on the ground and kind of have a feedback loop. So hopefully this work I'm doing, I can use to kind of then bring back to the systems, including primary care. Rob, do you Yeah, feel free if you have anything to
Well, I
add.
think I think Ian's point is really well taken that the risk is so much more diluted in primary care. It'll be interesting to see whether there's an impact in that population of folks where the risk is lower.
Totally.
All right, if there aren't any other comments, we can end there. Julianne posted out, please, if you haven't already, consider signing up for our mailing list. Click the link in the chat. Find out about more of our talks. Thank you again, Taylor. It was so nice to have you with us today.
Yeah, thanks so much for having me. I really appreciate it.